Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer.
Hello, I'm Dr. Carol Weisham, Clinical Professor of Medicine at the University of Washington School of Medicine in Spokane, Washington. Welcome to this program called Frontline in Type 2 Diabetes, Advancing Care with Basal Insulin Excellence. We'll begin with Chapter 1 of this four-part series entitled Guideline-Based Use of Basal Insulin. Joining me today in this discussion is Dr. John Anderson, who practices internal medicine at the First Clinic in Nashville, Tennessee. Welcome, John. So nice to have you.
Great to be with you, Carol.
Today, we'll discuss the American Diabetes Association, the American Association of Clinical Endocrinology, and other major guidelines indications for initiating basal insulin, as well as looking at where basal insulin fits in the context of overall diabetes therapy. So let's begin, John.
So insulin still, Carol, we've talked about this, it's still a cornerstone of diabetes treatment. There are approximately 537 million people with diabetes worldwide in 2021, and this has risen to about 783 million projected by 2045. Up to 40% of people with diabetes, that's 150 to 200 million people globally, will require insulin therapy. And due to the progressive nature of diabetes, many people with type 2 diabetes eventually will require and benefit from insulin therapy. The natural history and progression of type 2 diabetes sort of shows us why we may need that therapeutic intervention with insulin. We know that the defects in type 2 diabetes start to occur long before we have the dysglycemia cutoff point, which is somewhat arbitrary. And this is in the face of insulin resistance. And at some point in time, the beta cells of the pancreas can't produce enough insulin, and you start to have initially a postprandial rise of glucose and then a fasting glucose rise. But you can see on the chart that insulin levels and beta cell function continue to decline throughout the history of type 2 diabetes. And while the microvascular changes start to occur when the dysglycemia occurs, the macrovascular risk actually starts to accumulate even in the pre-diabetes phase. So you can see with declining insulin levels, with declining beta cell function, it's not surprising that many of our patients will need insulin therapy.
Yeah, and 2/3 of the population of the United States will not eventually get diabetes, and they can make insulin just as much as they need and not ever run out, so to speak. So it is really the insulin defect that defines diabetes. And as Fred Banting said 100 and some years ago, it's due to a deficiency of the internal secretion of the pancreas, and we have to replace that. And that's what we're doing with insulin therapy.
Exactly. And there are current treatment recommendations for basal insulin use in patients with type 2 diabetes. And Carol, you alluded to these organizations. The American Association of Clinical Endocrinologists says that, if you've got an A1C greater than 10% and glucose is greater or equal to 300 with symptoms, you may need insulins, particularly if there's weight loss. And in patients already using 3 to 4 glucose lowering agents and unable to meet goals, the first injection should be a GLP-1 or a GIP GLP-1 agonist. But if the goals are unmet with a GIP or a GLP-1 receptor agonist, then insulin may be needed. The American Diabetes Association says that, again, symptoms of hyperglycemia with polyuria and polydipsia may need insulin, evidence of ongoing catabolism, weight loss, weakness, ketosis. Patients with A1Cs, again, greater than 10% or glucose is greater than or equal to 300, you may need insulin. And of course, as we mentioned before, the longer the duration of type 2 diabetes, you may need insulin. The Endocrine Society says insulin should be used sparingly to reduce the risk of hypoglycemia. And if we're going to use insulin, let's keep the treatment regimens as simple as we can for the patients.
And just to be clear, that they were really referring to people who were at 65 years of age or older in their guidelines. They haven't written a general guideline that I'm aware of.
So here's the problem. And Carol, you know this. In a series of 22 studies conducted over a 10-year period of time with people with type 2 diabetes, we're initiating basal insulin way too late. The median time to insulin initiation is over 5 years. And when the insulin is initiated, the average A1C is somewhere between 8.7% and 9.8%. And a vast majority, 71% of primary care physicians and clinicians, didn't initiate insulin until elevated A1C levels were confirmed twice, which just contributes to that clinical inertia.
Well, and that's particularly concerning because studies show that even 1 year delay in starting insulin or any therapy to improve glucose is associated with increased risk of complications, both micro and macrovascular complications. So it behooves us to get on top of this sooner. We're going to talk a little bit more about barriers in the later part of this presentation, but obviously there are barriers that are associated with getting insulin started. Some of those barriers, hypoglycemia, weight gain. Well, I just want to show you a couple of uh, or a study that looked at the association between A1C and, first of all, ability to get to target A1C less than 7%. And as you can see, higher the A1C when insulin is started, for instance, at greater than or equal to 9.5%, the proportion of patients who reach A1C target of less than 7 is only 34%. However, if insulin is started at less than 8%, that means that 75% of those patients will actually achieve glycemic goals. So it's important to think about what our goals are, and we're going to get there more easily if we're more aggressive in starting the insulin sooner. Furthermore, weight gain is also associated with starting A1C. So the lower the A1C is at starting, the less weight gain it is. And look at the A1Cs of 10% or greater. They had an average weight gain of 10 kilograms or more, as opposed to those that had lower A1Cs at starter, which were less than 2 kilograms. So, really key if you're trying to avoid weight gain, again, better to start it early. Not showing you the data here, but also hypoglycemia is less when you start the insulin at an earlier stage. So again, just highlighting the importance of discussing insulin early and getting insulin started as early as possible. Now, we talked a little bit about barriers, and these are some of the barriers that people have found in the literature. Their patients have their barriers. They're not sure that insulin is working for them. They're afraid of needles. They're not confident that they would be able to titrate. They're concerned about long term adverse events as well as the impact on their social life. On the other hand, healthcare professionals, they don't just perceive it, they're getting real patient resistance to starting insulin. And many of them just don't have the system set up in order to start insulin easily in the office, between just not having their office staff being able to train the patients, having time constraints. There's just real barriers for them to be able to start it as well. And then there's, of course, give me 3 more months, doctor, the therapeutic inertia that we all see. And obviously, it helps patients if they're educated, they understand the pathophysiology of diabetes, the insulin deficiency occurs. If they're well aware that this is part of the natural history of the condition and not a matter of them failing to take good care of themselves, I think it would be helpful. In addition, we need to really work to give our patients the empowerment to titrate their own insulin so that they can find the right doses to get their blood sugars under control. So now we'll have a brief time for reflection. Think about the following question and how it relates to your practice. What are the barriers in my own practice among my colleagues and staff, as well as my patients, to using basal insulin? So, John, can you discuss some of the barriers to basal insulin that you see in daily practice?
I'd be happy to. One of the things we didn't talk enough about is that we have a lot of patients who have a lot of mythology about, insulin. They may have had a family member who's had insulin and then they had a catastrophic event or a complication, forgetting the fact that probably that patient needed to be on insulin before. But there's a lot of self blame. If I had taken better care of myself, Carol, if I had done what Dr. Anderson had asked, maybe I wouldn't have to be on insulin. The other part is when you start mentioning insulin, a lot of patients think, oh, wow, now my diabetes is really serious. I must be getting worse. They are worried about the injections themselves. They're worried about the social context. I might have to carry this out to dinner with me and give myself insulin with meals. There's a lot of diabetes distress that goes in there. And Carol, you see this every day, and it's really our job when we're talking about when that right time for insulin comes is to be able to have that conversation with the patient and say, what are you worried about? What are your fears? And have an honest conversation and sit down and spend a little extra time addressing those.
I also find it really much easier is if I have that conversation from the first time I see the patient about, what the future is going to look like. Additional medications are going to be needed over time because you're going to need more because your pancreas is making less. Eventually, all the medicines we have for diabetes are not going to be enough and insulin is going to be needed. And then, sprinkle that conversation through subsequent visits so it becomes something that they're not hearing for the first time and that you're having to overcome the shock and all that emotional baggage that the patient has about starting insulin. So again, I think this statement that I read saying that patients are not so fearful of insulin, they're just more concerned about what insulin represents in their medical condition.
And I love the fact that you say, set those expectations early so this doesn't have to be some tremendous surprise with a long duration of diabetes.
Well, and the more surprise it is, the longer it's gonna take you to try to unpack it at that time, and you can have those conversations about what it means and get their emotional side of their concerns out of the way before you actually start it.
I agree.
Well, starting incretin therapies before insulin has really helped smooth the way to starting my patients on insulin. I had seemed like I have a lot fewer barriers and they're ready to go once they've already experienced the injections of their incretin therapy. Thank you, John, for the conversation. I think it was really helpful. I think it's important to just remember that insulin is a core treatment strategy to achieve glycemic control in patients with diabetes, and it should not be thought of as a treatment of last resort. And as we discussed, it's very important to unpack the patient's concerns to address them proactively. Starting basal insulin earlier is associated with lower rates of hypoglycemia and less weight gain. We now have multiple basal insulin agents that are available, including newer basal insulins that have longer half lives, less variability, and less hypoglycemia. Thank you, John, and thank you for joining us.
Thank you, Carol.
Hello, I'm Dr. Jay Schuberg, a professor and the director of the Diabetes Institute at Touro University of California in Vallejo, California. Welcome to this program called Frontline in T2D, Advancing Care with Basal Insulin Excellence. We'll begin today with Chapter 2 of this four-part series entitled Initiation and Titration, Practical Approaches. Joining me today in this discussion is Dr. Neil Skolnick, a professor of family and community medicine at the Sidney Kimmel Medical College, Thomas Jefferson University in Philadelphia, Pennsylvania. Dr. Skolnick, we are delighted to have you here today.
And Jay, it's so great to be here with you. I love teaching about diabetes with you.
Well, we're going to have some fun. Today, we will discuss best practices for initiating basal insulin and titration protocols, and then talking about ways through a case discussion to optimize basal insulin management. So let's begin.
So, Jay, in theory, utilizing insulin, which is what we're going to be talking about for the next 12 minutes or so, should be easy. But one of my favorite philosophers, Yogi Berra, said, in theory, theory and practice are the same. In practice, they're not. And so we're going to go over the details of how to do it. Now, if we think about physiologic insulin release, there is a basal amount of insulin that is released throughout the day that combats the liver's gluconeogenesis. So it keeps our sugar down in a fasting state. But of course, we don't fast all day long. And when we eat, the pancreas responds to elevation of glucose with a elevation in insulin release. Now, that's under normal circumstances.
So let's look at how that is applied to exogenous pharmacologic insulin replacement. We know that there's a basal insulin need that will be required for arresting metabolic needs and that will suppress gluconeogenesis from the liver overnight and between meals. And that is relatively constant over the course of the day, albeit there is a slight decrease in the middle of the night and a slight rise early in the morning. And overall, if you're replacing insulin, it's about half of the total daily insulin needs. Now, it's not today's topic, but often we also need prandial insulin, which will limit postprandial hyperglycemia. And physiologic has a two-phase release, and we try to mimic that when we give exogenous insulin.
And so here are some graphs of the time to onset and length of duration for different insulins. And of course, the rapid onset insulins come on more rapidly and they're of shorter duration. Then we have intermediate insulins, and then the 24-hour a day insulins, which have a smoother curve, more linear pharmacokinetics, and last either almost 24 hours or a little bit more than 24 hours. Jay?
So, as we think about times that we would start insulin, I think it's important to have a plan, right? So, when someone is newly diagnosed and we're really not sure what type of diabetes they have, insulin is always the safest treatment to use. Certainly, if someone has a fasting glucose greater than 300, the ADA recommendations recommend starting a basal insulin. Or if a patient has catabolic symptoms where they have the polys and weight loss, or that associated with a fasting glucose greater than 200, you might consider starting insulin then as well. Insulin is always the right choice for treating hyperglycemia in pregnancy. And then I think it's also important to think about using insulin when you need rapid glucose control or you have complicating factors that might make starting other medications more difficult. And insulin is always the option of choice, typically in hospitals or when someone has a serious systemic illness.
Jay, we provided this slide as a resource for our viewers. And the one thing I'll point out is among the what are called daily insulins, Detamir isn't quite 24 hours. Glargine, even though it is listed as 24 hours, sometimes doesn't last a full 24 hours. That's important to be aware of.
So, there are other factors that are important as we think about this. And this is not to make it complicated, but just know if your patient is having an issue, it's important to think about things like the injection site. Are they injecting deep enough, or are they trying to inject between layers of skin? Think about the volume of injection. There is such a possibility as scar tissue, so always look at injection sites so they're injecting in an area where they can absorb. And there are things like body temperature and exercise that also will affect it. This is intended, all insulins that we give by injection are given subcutaneously, and it's important to recognize that we want to balance the benefits with risk factors or side effects of these meds. Neil.
Jay, let's go over now how to start and then titrate insulin. And this is one of those areas where if you ask two endocrinologists, you will get three different opinions. And so let's acknowledge that there are a lot of right ways to do things, but the main thing is you have to do something. You have to start insulin on time, and then you have to titrate up the dose. The method that I like best is called the Canadian algorithm, and that's because it was first studied in Canada. And I like it because it's simple. And that is starting with 10 units daily of a basal insulin, and then give the patient a morning fasting goal. It can be 100, it can be 120, 130. We can get to our goal incrementally. Give them a goal that is safe and makes them not worried. And then, as long as their fasting is above that, they can self titrate by 1 unit a day. What that means is that if my math is correct, start with 1 unit a day at the end of a month. Guess what? We're up to 40 units a day. Now, again, theoretically that works, but in reality, a lot of people get a little bit uncomfortable and don't fully titrate to that. But that's why we see them back. Jay, your thoughts about the different algorithms?
Yeah, first of all, I think it's really important for our viewers to know that there are recommendations and there are plans for starting insulin and titrating. So I like what you mentioned that you're never wrong starting 10 units. I personally like a weight-based dose, and you can see that ADA and ACE have different weight-based dose based on A1C. But more importantly, wherever you start, give the patient the power to adjust the dose. And there are a couple different scales there, or a couple different titration algorithms. And I would say good evidence has shown that patients can manage titrating insulin as long as you give them some parameters, which we're going to talk about. So, what are some best practices for starting basal insulin? And this is just the outline. I'll go into just a smidge more detail. Let's try to make sure the first injection is supervised. So let's do that in the office. For many people with type 2 diabetes, we might fix the fasting first, so basal insulin is ideal for that. Think about using a weight-based dose. Please make sure you set a titration schedule for the patient, and that titration schedule should have a ceiling dose when it tells the patient to stop titrating. And then please, when you bring them back, please make sure you look at injection sites so that you know they're getting the insulin they think they're getting. So let's talk about each of these just a bit more. Fix the fasting first. As Neil mentioned, let's have a shared fasting glucose goal, which will help them get to an A1C goal. But we're doing things quicker than the A1C will change. So picking a fasting glucose goal as a guide is a great place to start. Whether you use 10 units or you're doing a weight-based dose, I've given you what I typically do. You want to start with a dose that's going to let the patient know it's safe. They can take this and they're not going to have side effects such as hypoglycemia. And then set that titration scale. And I had a very wise physician once tell me, I think his last name was Skolnick, that any map will do. And so, whether it's 1 unit per day increase, or 3 units twice a week, or 5 to 7 units weekly, each of those will give you about the same titration. I like personally to do stair stepping, so I would do weekly titrations because I find that patients can see that their insulin's working. But all of them are evidence based and they all work. And then just finally, let's set those parameters for the stop titration. So if they achieve that agreed upon fasting goal, that's a great time to stop titrating up. If they have a hypoglycemic episode, please stop and contact us. Or if they get to that 0.5 units per kilogram per day, that ceiling dose is really where someone should stop titrating and reassess with their clinician. Be careful not to overbasalize. We talk about if you go above 0.5 units per kilogram per day, it's a great time to stop and maybe look up and make sure that we're seeing the benefit that we want and we're not getting 2 grades of decrease overnight. We talk about the beam, bedtime to AM. Make sure there's not more than a 25-point drop or 50-point drop overnight, because that might mean that we're giving too much basal insulin. And there is good evidence that if you go above 0.7 units per kilogram per day in the absence of other treatments, that you're actually increasing the risk of weight gain and hypoglycemia. So these are great steps that I think can help you be successful with basal insulin. Neil.
Jay, now we'll take a minute for reflection. Think about the following questions and how they relate to your practice. First, how am I titrating basal insulin in my patients? And the second is, are we getting our patients to goal? So now I want to take a moment to discuss something really exciting. So we've recently had approved the first weekly insulin, insulin icodec, and currently at the FDA under review is insulin efsitora. The idea of weekly insulins is pretty exciting. Remember, instead of what that means for a patient is instead of 7 shots a week, it's 1 shot a week. Now, it will take some getting used to because the dosing is going to be very different than what we're used to with daily insulins. Not surprising, with the weekly insulin is also something that we'll have to get used to and understand well. But I think this is an area where both clinicians and patients are looking forward to having basal insulin available in an easier formulation. Jay?
Yes, that is indeed exciting, and I think that will change the way that we manage diabetes. So let's take what we've learned so far and apply it to a case. Maria is a 58-year-old female who's had type 2 diabetes for about 10 years. Her current weight is 100 kilograms, and you could see she's on multiple medicines. She's on metformin, glipizide, algliptin, and on glargine 10 units daily. And she's frustrated. It was a really big deal to start insulin, and she felt like she was not getting the response that she really thought she would get when she started insulin. Her morning glucoses are still high, and she's been checking like you recommended. And she feels like, this was a big deal, and she would expect to see some kind of improvement. Neil, what are your thoughts?
I think the most important thing here is action. One could stop her insulin, stop her DPP4, and just add a GLP-1. That's one option. Another option might be to stop her glargine and make sure that she's titrating, which it turns out she hasn't been doing. Since she's already on insulin, we'll take that route to where we're going, and we give her instructions about how to titrate. We stop her sulfonylurea, so we diminish the risk of hypoglycemia, and let's see what happens. And it turns out she comes back in after doing that. We had stopped her glipizide. We increased her glargine slowly to 20 units. She then titrated up to 37 units over the next few weeks. She's not having any hypoglycemia. Her AM readings are 100 to 140. After dinner, she's 100 to 180. And guess what? Her A1C is now down to 7.3. Jay?
Yeah, and I have to say that, patients are happy when they see the results that they're expecting. And I love this example because you can see what a difference titration makes, both for the glucose control, but also for patient satisfaction. So let's now have a minute for reflection. Think about the following question and how it relates to your practice. What strategies am I going to employ when I go back into the clinic system so I can improve insulin titration and reduce clinical inertia? We have a wide spectrum of insulin choices that really allow us to individualize our treatment of our patients. And having some knowledge about the way time action curves work for insulin really allow us to improve efficacy and safety for our patients. We have newer long-acting insulins that appear to be safe and effective for our patients and really probably will improve patient adherence. And I would just say that, having some knowledge of some basic calculations about utilizing insulin can really help both you and your patients achieve those goals. Neil, thank you for joining us today. It's been my pleasure.
My pleasure as well, Jay.
Hello, I'm Dr. Jay Schuberg, a professor and the director of the Diabetes Institute at Touro University, California, in Vallejo, California. Welcome to this program called Frontline in T2D, Advancing Care with Basal Insulin Excellence. We'll begin today with Chapter 3 of a 4-part series entitled Addressing Barriers, Adherence, Hypoglycemia, and Injection Burden. Joining me today in this discussion is Dr. Neil Skolnick, a professor of family and community medicine at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia, Pennsylvania. Welcome, Neil. We're so delighted to have you here.
And Jay, I am delighted to be here with you. This is going to be important information.
So today we will discuss some common reasons for insulin use inertia, strategies to overcome fear of injections, weight gain, and hypoglycemia, and tools to support adherence and communication with your patients who are taking insulin. So let's begin. Neil, you want to take us off?
So Jay, we sometimes think insulin should be easy to start, but it isn't. And there are both patient barriers and there are clinician barriers. Patient barriers are many. They include patients sometimes see insulin as a sign of failure. They now need insulin. There might be concern about weight gain, which is quite legitimate. Concern about hypoglycemia, also a real concern. There also might be disinformation. I've had many patients go, I don't want to start insulin because I had a relative start it. And after they started, something happened, a heart attack, an amputation. And then it gives us an opportunity, as we'll talk about later, once we know those barriers, to talk about them. How about on the physician side of things, Jay?
Yeah. So I think it's really important that most of these barriers are misconceptions. And so when we look at the patients, you've really mentioned things that we commonly see. On the clinician side, many clinicians think of insulin as complicated and dangerous. And again, really focusing on that fear of hypoglycemia. And that there's going to be a lot of work on our side to burden both the patient and myself. And so that ends up causing things that make it a little bit harder. Or maybe we don't feel like we don't have the support staff that really would help us to help our patients. So, because of those barriers, both patient and clinician, we know there's been a delay in insulin initiation um, after oral agents for really a number of years. And this clinical inertia can contribute to preventable complications. And I think we can do better for our patients.
I agree with you, Jane. There's not only delay in starting insulin, but even once we've started insulin, there's a study of real world data from a United States EMR database that shows that 38% of patients achieve their A1C target of less than 7% within 12 months of starting insulin, but only 8% over the following 12 months. So even when we start it, we're not always great at titrating it up. Another study where patients and providers set individual A1C targets at week 12, only 27% achieved the agreed upon target. So the learning points here are when you think about starting insulin, address those barriers. And once you start it, make sure you're titrating it adequately. When you think about it, you want to try to achieve those targets within 3 months. The ADA recommends treatment intensification every 3 to 6 months if you're not at an A1C goal that you've set, and timely intensification use of insulin to really get going with it. Only 31% of eligible type 2 diabetes patients had treatments intensified when they were not at goal. And another study found that of those who did not achieve target glucose at 3 months, they were less likely to achieve it at 24 months. So once you start insulin, make sure you stay on top of it. And that's a time where, Jay, I'll often see people back more frequently than the usual 3 months, maybe every month, to make sure that they're titrating up the way that we had set.
Yes, I love that. Touch points are critical here. So, what are some key steps? And Neil already talked about the important point of having a plan, letting the patient do it, those touch points. Remember, we have the power of insulin at any time throughout the course of diabetes. And so I think the sooner we use it, the more patients will to forget that kind of myth of insulin is a weapon, or once I start insulin, I'm on insulin forever. And I do think we talked about the benefit of like, let's give that first injection in the office. Because I think, again, that could be a really big change for a lot of people. And then having a plan for your insulin, start a weight based dose, give the patient a titration plan, and give them a ceiling dose. And let's let them see the power of this insulin. So if we're using basal insulin, they usually use the morning glucose as a measure of whether they need to adjust. And then when we bring them back, let's see where they're injecting. And sometimes I'll even have them demonstrate how they're taking the insulin so we know they're doing it correctly. And these things can really help you and the patient keep on that very effective treatment plan. So when we think of barriers of injection, I think it's really important that many people don't know what injection actually feels like. And I often tell people your finger stick glucose is the most painful part of diabetes. Taking an insulin injection with a pen, with a 4 to 5 millimeter needle, with a 32 gauge, is often not felt at all when the pain is much less, if anything, than a finger stick. And that's not something that might come naturally for people who don't have medical experience. So giving them the opportunity of a supervised first injection can really work, and making sure that they have the opportunity and the skill set to do it well, because that's going to empower them to feel good about this treatment. And I'm often surprised that people, when we do a dry injection in the office or once we start insulin, they say, boy, this was a lot easier than I thought it would have been. And again, I think that's something that we can really make as a positive experience. And now there are new insulin options. There's newly approved insulin icodec, and at the FDA, investigational insulin accessoria that are going to give us the opportunity for once weekly insulins for our patients.
Jay, that's really exciting about the weekly insulins. When we sit down to talk to patients, two major concerns that we alluded to earlier that they often have are concerns about hypoglycemia and concerns about weight gain. I think those are real, they're important, and they're things that we can address. As far as hypoglycemia, we acknowledge that that's a possibility, and we explain to patients that we will be careful with titration in order to minimize the likelihood of hypoglycemia.
Yeah, and I think this is so important. I think the other part of this is that because we've used insulin as the last treatment, we've really set up that weight gain and hypoglycemia as a risk factor. And if we use insulin earlier, we can really reduce that.
Really good points, Jay. We talked about clinician barriers. And when it comes time to discuss things, we want to use a shared decision making model, which means we present the idea and then we listen for the patient's concerns. Remember, God gave us two ears and one mouth for a reason. Listening is important. And so the patient can then share their concerns, and we can then tailor our discussion and response to the specific concerns that they have. And then we decide together. We know that control of A1C is important. Here are all the benefits. We talk about the decreased likelihood of kidney failure, of diabetic retinopathy, neuropathy, etc. And we acknowledge the concerns that they have that we can mitigate, and then we make a decision together. Jay?
And I always like to say that we don't have to go it alone when it comes to helping our patients with diabetes. We have some really exciting tools that allow us to help our patients. So, for those patients with type 2 diabetes, the use of a CGM is largely covered, continuous glucose monitor, and you have multiple different CGMs that you could utilize that are available by prescription in type 2 diabetes. I think it's also important to recognize that we have lots of colleagues in the healthcare space who can help us with both problem solving for our patients with diabetes, helping with titrations, and helping sometimes even de escalate treatments because often when you start insulin, you can stop other medications. So, whether that's an educator or a nurse led program or a pharmacist led program, utilize your team to help you help your patients because those touch points make a difference. And now we even have smartphone apps that will help us calculate our insulin. So I think there are lots of good tools available for us and our patients so that we know that we're not going alone and we can help our patients achieve their goals. So we have a stop and reflect. Think about the following question and how it relates to your practice. What has been the biggest barrier to insulin use in my practice? And how am I going to address it? Is this patient driven, clinician driven, or both? So Neil, I'd love to hear your thoughts about, what are the barriers that you've seen in your practice or in your colleagues and how do you address them?
Jay, I think for a lot of our colleagues, one of the barriers is simply knowledge, thinking about insulin, worries about hypoglycemia, how to titrate. We've addressed that. But then when I think about my own practice, I think the barriers honestly are in two areas. One are the patient barriers we discussed. And on my end, it's emotional. I mean, the difference between AI and us is I have empathy. When my patient is disappointed or doesn't want to use insulin, I feel for them and then I become reticent. So for me, the introspective moment occurs when I know that's going on and I know that even though empathy is often a good thing, here it's not a good thing. And I can use that empathy to relate, but then I need to continue on with what I know is the right thing for the patient. So a barrier for me is often the patient's reticence that I feel, and then I need to have the confidence to move ahead with my recommendation.
Yeah, really good points. And, I would say my work with patients, insulin is going to be a required treatment for almost everyone I have with type 2 diabetes at some point. And so I love to start those conversations very early on to say, our initial treatment could be insulin or these other agents. And then when they're coming around other times where insulin would be a good choice, I offer it then so they know it's something that I use and I can often start and stop and then let them know that there is no simpler, quite honestly, in my opinion, and more effective treatment than insulin. And by having that confidence and one, having taken injections myself, There is no injection barrier. I know what it feels like. I can do the injection with the person. Of course, my injection will be a dry injection, but I think it really gives them a chance to know that this is something I'm comfortable with and something that, we want to use it as an ally, not as a threat.
While we have a number of bullet points on this slide, I just have a few parting thoughts. One, understand what many of the barriers may be, and then after introducing the idea of insulin, ask your patients what are their concerns. Listen and write this is typical motivational interviewing. Then address those concerns, also being clear on the benefits of insulin.
We thank you very much for joining us today. It's been our pleasure. Neil, always a pleasure to present with you.
You too, Jay.
Hello, I'm Dr. Carol Weisham, clinical professor of medicine at the University of Washington School of Medicine in Spokane, Washington. Welcome to this program called Frontline in Type 2 Diabetes, Advancing Care with Basal Insulin Excellence. We'll begin today with Chapter 4 of the 4-part series entitled New Emerging Therapies, Once Weekly Basal Insulins. Joining me today in this discussion is Dr. John Anderson, who practices internal medicine at the Frist Clinic in Nashville, Tennessee. Welcome, John. So nice to have you here.
It's great to be with you, Carol.
Today, we'll discuss key clinical trial data for once-weekly basal insulins and practical considerations for how they might be used in practice. So let's begin, John.
So, one of the things we need to look at is what's the non adherence to daily basal insulin therapy? About 69 to 87% of patients reported missing basal insulin dose injections. And about a third of patients reported missing basal insulin dose injections at least once a month. And what we really know is that if you miss anywhere between 3.6 to 4.3 missed doses in a single month, that's going to significantly impact your overall glucose control. And when we look at why, patients will say, I'm too busy. I'm traveling. I skipped a meal. Well, probably doesn't apply to basal insulin, but patients think that way. Emotional stress, the embarrassment of injecting in public, the challenges of remembering at the same time every day. So there's a lot of reasons why patients will admit to some non-adherence. So what we also know, and we've seen this before, fewer injections are associated with improved adherence. So 365 injections could be 52 injections if you just were able to do a once a week formulation. And we know, Carol, what we've seen over time is that with the GLP-1 receptor agonist or the dual GIP GLP-1 receptor agonist therapies, they're associated with significantly better adherence than once daily formulations. And when we had once daily formulations first on the market, they were better than twice daily formulations. So it would be reasonable, I think, to expect similar benefits observed with once weekly injections of basal insulins. And so the weekly insulins, as seen here, have a much longer half-life. And the newer novel basal insulin analogs, which are glargine U300 and degludec U100 and U200, truly are much more physiologic. But if you see here, you can see that icodec U700, 197-hour half-life. Efsitor U500, a 408-hour half-life. So truly long-acting insulins.
Can I just highlight something that you said, but I just want to make sure that the audience picks up on? And that is these newer insulins are formulated in concentrations. So in the case of icodec, it's U700. In the case of Efsitora, it's U500. And so you're not like injecting, several milliliters of insulin once a week. It's a very small volume, very comparable to what they would be taking if they were taking equivalent amount of insulin daily basis. And let's talk about the clinical trials for once weekly basal insulin. We have the newly approved icodec and the investigational Efsitora. John, could you start by discussing some of the clinical trial data we have with these insulins?
I would be happy to, Carol. So the once weekly basal insulins have similar or superior efficacy as once daily basal insulin in insulin naive patients here with type 2 diabetes. So these are the insulin naive patients. First, we talk about the icodec patients, and onwards one in a basal initiation, icodec versus glargine U100. Not only was it non-inferior, it was superior in nature. If we look at onwards 3, icodec again versus degludec, you can see that it met the criteria for both non-inferiority and superiority. And then onwards 5, it was icodec, and patients were given a titration app to follow. And again, you can see that there was superiority versus other daily basal insulins. With Efsitora, again, in insulin-naive type 2 patients in Quint 1 with a fixed dose titration, Efsitora was non inferior to glargine U100. And then Efsitora again, and you can see the starting baseline A1Cs was non inferior to Degludec.
I think so that's important that whenever new insulin is being studied, they want to prove that they are at least as effective as what's on the market. They're never going for their primary endpoint to be superior. Superiority is a secondary endpoint. So in this case, we can say that both icodec and efsitora are s- are non-inferior. They're equal to their comparators. But in the case of the icodec studies, they had a statistically significant superiority.
Right. Correct. And then if we look at the patients who are insulin experienced, who are already on insulin, we can see that in the icodec, in these insulin experienced patients with type 2 diabetes, in other words, two, there was a basal switch and icodec versus degludec, and they met that criteria for non-inferiority, but also statistically had superiority. And if you look at the onwards 4, which is a basal bolus switch between icodec and glargine U100, they met the criteria for non-inferiority. Again, in the insulin experienced patients with type 2 diabetes with Efsitora in Quint 3, there was a switch from basal insulin, and Efsitora versus degludec, again, showed that non inferiority that's really important, Carol mentioned. And then in Quint 4, where they replaced the basal and multiple daily injections, Efsitora again met that criteria for non inferiority versus glargine U100. Once again, showing these new weekly insulins were non inferior to the study comparison versus those other basal insulins.
Yeah, and that's again very important. Well, some people might say, my goodness, with these very long half lives, it must take forever for the A1Cs to reach target. And what both of these slides show, which were in insulin naive patients, they showed that the A1C reduction mirrored that of the once daily comparator almost identically. So we can get the A1Cs down, and we get them down quickly, and it's not a delay as long as the patients are adequately titrated. Now, as far as safety outcomes, on the top, we're talking about hypersensitivity reactions and insulin site reactions, in this case with insulin icodec. And you can see that the numbers are kind of up and down, but overall, no significant difference in either of those events in the clinical trials. Dropping down to looking at hypoglycemia, either clinically significant hypoglycemia or severe hypoglycemia. Once again, the numbers are above and below 1, but the numbers of events were actually quite small and were not really significantly different amongst the studies. So moving to insulin efsitora, the hypersensitivity reactions and injection site reactions numerically look to be slightly greater in the efsitora versus the daily insulin, but these were not statistically significantly different. The rates were so low. And if we move down to hypoglycemia, again, the rates are above and below 1, but not statistically significantly different between the once weekly and the once daily options. Studies have been done to investigate these. And in the case of the first study, this was done with insulin icodec, and they were looking at patients who were given either 2 or 3-fold increased doses of icodec versus glargine, and they showed no significant difference in hypoglycemia. In the second study, again, they did it under multiple different conditions: fasting, fasting with exercise, fasting without exercise, as well as in the case of patients who were taking a double dose of efsitora. And once again, no significant difference in hypoglycemia. And overall, both of these studies showed no increased risk of hypoglycemia. There was same nadir glucose in both studies with both types of insulin. So again, really helping to alleviate the concerns of that these lasting insulins are going to cause long lasting hypoglycemia when they occur. So let's talk a little bit about some practical uses. And so I'm going to talk a little bit about starting these newer insulins. So in the case of, we're going to start with insulin icodec. If you have a patient who is naive to insulin, you would just start them on the equivalent of 10 units a day or 70 units once a week. So that's easy without an issue. So let's talk about efsitora. So patients, again, not on basal insulin coming into this study, they found that patients did better if they gave them a loading dose. In this case, it was a 300 unit loading dose. So in starting patients, their first dose would be 300 units. And then their second dose, when they go home to take their second shot, it would be 100 units a week. And this is equivalent to about 14 units daily. And then in both cases, patients would be titrated according to the schedule, which we'll talk about a little bit later when we talk about the case. Now, what about if patients are already on basal insulin? And so let's again start with icodec. So they're already on insulin. The first question you ask is, how far are they away from goal? So if they're far away from goal, what you would do is you would take their total daily insulin, multiply it by 7 for their weekly dose, and their first dose would be 1.5 times that. And then you would go ahead and titrate. For the F Satora, again, if the patient is using insulin, then what you would do is you'd take their total daily dose of insulin times 7, and that would be their weekly insulin dose. Now, they do suggest that if patients are on BID, NPH, or on U300 glargine, that you lower that dose by about 20% to be on the safe side, since we know both of those are somewhat less bioavailable and active than the newer insulin analogs. So, if the patient, again, is closer to goal, and in the study we did, fasting glucose was above 120, again, we multiplied the prior basal dose by 7, and then we multiplied it by 3 so we could correct the glycemia more rapidly. And in both cases, you'd round the dose to the nearest 10 units. And then, of course, titration is essential. So, John, what in your mind, as you look forward to using these new basal insulins, what patients do you think would be most appropriate for them?
That's a great question, Carl. When we were first discussing these weekly basal insulins, the first patient that came to mind is the older patient with cognitive or physical limitations, where perhaps family members are having to put 7 doses of a basal insulin in a refrigerator. Now, perhaps family members or caregivers can give this once a week. And I think about long-term care facilities, how much easier it would be for nursing staff and patients to be able to get a once a week dose. But then again, there's also the patient who's poorly adherent. They're busy. We saw all those reasons. I just can't find the time for this. Patients with a lot of comorbidity who have polypharmacy. As we've talked about before, if you're already giving yourself a GLP-1 receptor agonist or a dual agonist, you're already in a once a week habit. This would be an easy add on for the timing of your injections. And then anybody who's on orals and struggling, but they're hesitant about injections, you're decreasing the number of injections they have to give from 365 a year to 52. So people with work constraints, and then there's just the patient preference, right? If I would much rather do this on Sunday morning, I'd rather do that than every single night. And so there's a variety of patients for whom this is going to be very appropriate.
And I think patient preference is going to drive a lot of it as well, I think. I mean, it was like 93% patients would rather stay on the once weekly than go back to the once daily. So I think that really speaks volumes to the patient satisfaction that we can expect from these newer insulins. So let's go to a case. John, would you introduce the case?
So this is our theoretical patient, Joe, who's a 58-year-old man with a 10-year duration of type 2 diabetes. He's been in good control since diagnosis, no known complications, but he travels extensively for work, and he reports back during his office visit he's taking insulin is challenging, and he doesn't like to take it with him. He struggles with timing related to change in time zones. And currently, his medications consist of metformin XR at 1,500 milligrams a day, tirzepatide once weekly at 10 milligrams, insulin degludec at 30 units in the morning, rosuvastatin 20 milligrams daily, and his ARB losartan at 100 milligrams a day. He's got a BMI in the overweight category, but not obese at 29, and he's got a blood pressure that's well controlled at 118/72. Everything else is otherwise pretty normal on his exam. His A1C is not at goal, certainly not for a 58-year-old with an A1C of 7.8, but he's got a normal EGFR at 68. He's got an LDL cholesterol that's at target at 63, and he's got a UACR of 12 milligrams per gram of creatinine. So this is the patient that we're talking about today.
Well, I'd like to just go over the situation for what we would do if we were going to switch him to once weekly insulin. So, after discussing the options, he's really interested in the convenience of changing to the once weekly insulin, in this case, icodec. And his reasonings are that he can take it at any time, and if he is changing a time zone of 12 hours, it doesn't matter if he takes it in the morning one day and the night the next. It's not going to make any difference in actions. So, in this case, to calculate his dose, you would take his basal daily dose times 7. Okay, so 30 units times 7 is 210, and that would be his weekly dose. But then for that first dose, you would multiply it by 1.5 because he's pretty far from his target. So that would be a first time dose of 315 units. And then he should be instructed in writing to take the 315 units for the first dose and then 1 week later start the 210 units for the second dose. And then starting on the third week, then he should consider titration. And the titration schedule that was used in the ICADEC schedule, it was as follows. So if the median glucose of the past 3 days, that is that middle glucose of the 3 days, was less than 80, you would decrease by 20 units. If it was between 80 and 130, you'd keep the same dose. If it was greater than 130, you would increase by 20 units. So this is the equivalent of increasing or decreasing by about 3 units a day. And so he did so, and he comes back 3 months later. He has increased his dose to 280 units weekly and reports that he is taking his insulin on the same day as he takes his tirzepatide. He reports no hypoglycemia and no increase in body weight, and his A1C was 6.8%. Think about the following question and how it relates to your practice. What strategies am I going to apply when back in clinic to assist patients who I want to change from daily to weekly basal insulin? Think about your clinic, think about the personnel in your clinic, other people who will need to understand what this new insulin is going to mean in terms of education, et cetera. So let's just summarize. Once weekly basal insulins are promising options that address many of the barriers associated with once daily injections by both providers as well as by patients. Compared to once daily basal insulin, both Efsitora and Icodec offer comparable glycemic efficacy, similar safety profile, reduced injection burden, greater patient satisfaction, and the potential to improve adherence. And there was no increased risk of hypoglycemia under any conditions with either drug. Thank you so much, John. And thank you for joining us.
Thank you, Carol.
Please also follow the link below for a patient simulation CME program on basal insulin.